Dear colleagues, this case was referred to my clinic after orthodontic examination. During orthodontic examination on this 20 years patient, dentist paid attention to this strange area inside of the root and also the strange outline of these roots of obtuse 11. And in history of this patient, 10 years ago, trauma, about age 10, without some prominent luxation. No complaints, no pain, percussion negative, palpation negative, no pockets, no sinus tracts, negative cough test. What we see here is some area with, I think, obliteration. I can't see pulp chamber in the canal. I see some wide area here with also some radio-opaque inclusion inside. And my question, maybe we have here internal resorption. Also, we see some radiolucent area, or maybe widening of PDL and apical part of the root. And to be more clear with my diagnosis, I refer patient to CBCT. As we know, the suspicion of resorption is one of the situations that almost all professional organizations recommend to refer patient to CBCT. And we'll see now what we have on CBCT. On CBCT, what we clearly see the area of internal resorption with some radiopaque areas and normal periapics. What's important also that this internal resorption is not perforating one. It's influenced the decision to treat or not to treat, how to treat, and what to use during obturation. Final diagnosis. Differential diagnosis for the pulp. Vital pulp with negative or false negative. Cold test because of obliteration, or necrotic pulp. Normal periapics and internal replacement resorption, the rare form of internal resorption that together will have a process of resorption and creation of mineralized tissue. Okay, I started the treatment. The most important part during this treatment was to go to the canal through the obliterated part of the root. And in this specific case, I use a very interesting bore and a guide bore of company SS White. We have the bore like this also in a company Comet. I think it's very, very nice in cases like this. And of course, I use many factors to choose the path of insertion, the clinical examination of the tooth, the CBCT examination, understanding of inclination of the root in palatal direction, and it's the first part of the treatment. Second part of the treatment is choosing of appropriate night eye system, and I think in this situation with very curved canal, I prefer control memory wire system. Personally, I use here MS system, but of course you can use every multi-file system or from control memory wire like DC taper, receiver, true anatomy, doesn't matter. And what's most important, I think here, to use a scribic instrument that will be able to go inside of this unusual area of internal resorption. And a very good instrument here is XPF instrument. Company developed also XPFR, primary developed for red treatment, but in the white canal, and here I open this canal to number 40, I prefer to use XPFR. I think it's better with this diameter 30 than a regular one that was developed with company to work in canal 3004. And because I use this scribing instrument, I decided to finish this case during one visit treatment, and I finish it with combination system of obturation and gutta percha and BGM root canal filler, epoxy sealer with macromolecule inside. And it's very nice to see the final result. And we understand from final result in this area that we can see just sealer and no word gutta percha inside, when they said that this mineralized tissue was not freely embedded in the pulp. but maybe have some connection to the wall, and it's still now there. Okay, I think the case was interesting, and this is why I decided to show it to you. Have a nice day.